she's a senior commercial product manager at Elsevier. Let's give her a good welcome. Thank you.
Thank you so much, Dr. Omar, and thank you so much for all the members of the Saudi Spine Society for the generous hospitality. What a wonderful night yesterday, and the night before, even a downpour. I mean, who could ask for more? So I'm delighted to be here. It's a huge pleasure and honor to be talking about the methods and then the dissemination and implementation of this wonderful guideline. First of all, how did we come up with the low back pain as a topic? Of course, it has a huge clinical burden and healthcare burden, as we have heard, huge impact on the economy as well. So it was very clear from the start that this was a very strong candidate. You see here on the right-hand side the 12 topics of the clinical practice guidelines that are being developed as we speak, and 2 of them have already been published, the first 2, chronic kidney disease and dental caries prevention. Some of these topics might come as a surprise to you, and they came as a surprise to us as well. But it took a fairly elaborate and data-driven and need-driven process to arrive at them, starting out, of course, with the clinical burden parameters, but then very strongly also taking into account the so-called impact and effort factors together. And we have had several iterations of this list, which proved to be quite a diplomatic balancing act, of course. And oftentimes when we came up with a list and nearly got it approved, somebody among the many societies or other organizations already involved in guideline development stepped forward to let us know that there was already a national guideline available. So we steered away from those big hitter topics that you might have expected here, such as diabetes, obesity, and so on, in order, of course, to give those national guidelines the precedence. But, of course, there's enough work to go around. So we have ended up with a really eclectic and impactful list, I believe. So what was the methodology that we used? As Dr. May already indicated, we were trying to be as efficient as possible by building on existing work whenever possible, but also very clearly sticking to the best practice in guideline development, which was very much dominated by the work of the GRADE working group at McMaster University, who coined this phrase of the GRADE adolopment. It's a horrendous phrase, so I put beneath it what it means. It's a shortened version of adoption, adaptation, and de novo development of recommendations. So what you do there at the beginning is that you decide, of course, the guideline topic and what area you would like to address, in order to then do a systematic search for existing clinical practice guidelines in the area. You then assess their quality and currency, so how old they are, and whether they really are applicable and relevant, but also of sufficient quality. So once you did that, and that in itself can be quite an interesting process until you reach consensus, what guideline to start out with. You then, take those questions from that guideline. Potentially then during scoping, you might have additional questions that are added in. And then what you need to do is, of course, to then update the evidence base. So, for example, in our case, we started out with the NICE guideline and then updated all those literature searches going back to 2016. Whoever has already participated in systematic reviews, you will know what it means to run 61 systematic searches and wade your way through 25,000 abstracts to then arrive at those evidence syntheses, including forest plots. So it has been a tremendous effort, and of course it's a very collaborative one, because at all stages of the process, that clinical and local input is absolutely crucial. We couldn't have done it without the use of digital tooling, which is now available and getting better every day, including the use of machine learning, which is really an interesting new development in this area. Unfortunately, there's no single platform or interface that would guide you through the entire process, and I'm very hopeful that this will change in the next 5 or 10 years. I know that several companies are working on that, and I can't wait for it to happen, because at the moment it is a very disjointed process where you come out of one tool, go into the other, there's lots of copy-paste, manual effort in between, which is of course always very time-consuming and error-prone. But of course we stuck to those best practice methodologies, whoopsie, sorry, a little visitor, as much as possible. So at the end of this update, you then come together as a task force in order to then take into account the evidence base that has now been updated, but also those contextual factors that have already been mentioned, in order to then arrive at the recommendations. And these recommendations are called, they are adopted if they are taken on as they were in the source guideline, adapted if they are changed in any way, or indeed a new recommendation if the question was not present in the source guideline. You see here the entire process of guideline development. So we stuck to this religiously all the way through. I also indicated what tooling we used at each of these steps. And you can also see in the borders of each of these boxes who was involved. So you can see the advisory committee, or then at the end for approval, the Saudi Health Council Scientific Committee. They select the topic and then also give their final approval. In between, there's a lot of work where we ask, in particular, the input of the task force. You see this at the scoping workshops, and then the recommendation workshops, and then, of course, during the discussions about the actual guideline draft. And then those black rounded boxes, they indicate the work of the guideline support team behind the scenes. And finally, you see in this weird green color, the peer reviewer input. So huge call out to the international team who has provided that, and of course also our local peer reviewers. I already mentioned the workshops where the recommendations were made. We followed the rigorous, transparent, and systematic approach developed again by the GRADE working group called the Evidence to Decision Framework, where the task force comes together and discusses the best recommendation, going in turn through not only the evidence, the benefits and harms, but also patient values and preferences, the cost effectiveness, equity, acceptability, and feasibility of the intervention in order to arrive at a truly evidence-informed, evidence-based recommendation that is applicable locally and will hopefully find clinical adoption. So what does our dissemination channel look like? This is a little preview because the guideline itself is currently going through the approval steps. So we hope to have it ready on the Saudi Health Council's website within the next few weeks. But this is what it will look like. You see here the landing page if you come onto that website, and straight away from there, you can either just scroll down until you find, where is the thing? It doesn't show on the screen. Okay, never mind. There's a search box right there, and I just typed in already low back pain in order to then get very quickly to those recommendations, which most clinicians are interested in. They don't necessarily want to know all about the methodology. It might be of interest for some, but of course, you know, let's get to those recommendations. And immediately you land on the recommendations, indicating the certainty of the evidence as well, you can, on the right-hand side, and this is in particular interesting if you have a more eclectic set of recommendations, to filter by guideline, by age group, potential comorbidities, and so on. You can then dive down into the more detailed levels beneath that recommendation, including the so-called summary of findings tables. As you see, for each of the outcomes, for each of the comparisons, the results are presented there, either in this numeric form or then switched around for more text for those who prefer that. And then, of course, you can dive down into the full guideline at any moment. And this is this huge manuscript that our task force and of course our peer reviewers have worked through so diligently, and providing that background section, including classifications, the local epidemiology, and then into the very in-depth evidence summaries that was presented to the task force when they made that recommendation. You see the references always listed on the right-hand side, and the already mentioned forest plots, including the risk of bias assessments. So, in case you want to check out what the two guidelines look like that are already up there, approved for chronic kidney disease and dental caries, you can see this in action. And we very much hope that within a very short amount of time, you will have the low back pain guideline there as the third one to go live. I just wanted also to indicate that the dissemination alone was not what we did, but there was also a huge focus on how to bring those recommendations closer to the point of care. And one way of doing that is by utilizing order sets that are already integrated and available within electronic health record systems. They are known to reduce unwarranted variability of care, improve cost efficiency, drive quality and patient satisfaction, and of course very much looking at to minimize inefficiencies in the clinical workflow. But now they also provided us with the option to align them with the guidance sections and references in the recommendations, and so bring those that work of the low back pain task force right to the point of care. So we are trialing that as soon as the guideline is approved at several pilot sites across the country. So this is what it would look like. You can see here, for example, the acute low back pain order set for ambulatory care. On the left-hand side, the different sections of the order sets, and then the orders in the middle field there, and a clinician can simply tick the relevant orders they wish to make. But there's additional guidance there for them to look at, the so-called advisory text, which is always there. And for those sections that have the little icon there on the right-hand side, they can open up the guidance part. And that includes references. It includes the reference also to the guideline program. It lends itself not only to medications, but also other interventions. And before I hand over to Dr. Ahmed now, I just wanted to give a huge shout out and my heartfelt thanks to all the support we have received from the task force, in particular our clinical leads, and of course our valued peer reviewers, but also, as mentioned already, from the Vision Realization Office and the Saudi Health Council, many others that I wanted to mention here. With that, I would love to hand over now to Dr. Ahmed to present the results, the recommendations, and their local implications. Thank you so much.